Thank you for joining me. My name is Hans Bruhn. I am a risk manager at Ophthalmic Mutual Insurance Company, also known as OMEC. This risk management course is entitled Documentation Strategies to Minimize Risk. It was designed and developed in order to underscore the importance for patient care and patient safety, as well as defensibility of a medical malpractice claim. I'll be using actual closed claims that OMIC has handled for ophthalmologists that we insure to illustrate our risk management concepts and recommendations. Certainly, when we look at patient care, we are trying to ensure that the right care is provided at the right time. In the issue of defense of a medical malpractice claim, it's critical that your documentation show the care that was rendered as well as the reasoning behind that care. So therefore, many cases can become indefensible if there is a claim due to incomplete or inaccurate documentation. Poor documentation can, in fact, make good care look bad. And if it's not documented, it didn't happen. Those are all statements that defense attorneys have offered in their assessment of how important documentation is to the defense of a malpractice claim. Because documentation is a reflection of your thought process, the rationale and the considerations you made as you decided upon treatment for a patient. Up to 30% of OMIC claims have had documentation issues that have eroded the defensibility of a claim. So it is a real issue that we focus in on a daily basis. How probable is a medical malpractice claim? Well, we looked at the data from the Medical Professional Liability Institute, and they have shared their statistics that say that over a 30-year career of a physician, they can expect the number of claims that you see on the slide here. And in fact, only 5% of physicians can make it through a 30-year career without a medical malpractice claim occurring or an allegation, just an allegation of negligence. The probability of a claim, in fact, in any given year can be around 8%. OMIC has a 30-plus year experience insuring ophthalmologists, and in that data, we do periodic claim studies to just identify what causes a medical malpractice claim within a subspecialty within ophthalmology, or just in general, across all subspecialties of ophthalmology. OMIC insures only ophthalmologists. One area of claim activity, one reason for claim activity we found was in the area of diagnostic error. And we found that upward of 14% of OMIC claims had an element of diagnostic error. And 34% of those claims led to a payment of liability. This is just one sliver of why claims happen, in addition to documentation. You can see other claim studies that we have conducted based on OMIC claims on our website, omic.com. So, medical records, they need to be clear, concise, accurate, accessible to other parties when requested, legible, and again, show that logical train of thought. Who will see that medical record? Well, certainly these parties, when there is a medical malpractice claim, are going to be able to see your medical records and assess whether the type of care that you provided was prudent. That can be the patient, lawyers on both sides in your defense, as well as the plaintiff or the patient, a judge, jury, witnesses, and even to a certain extent the public. When a lawsuit is filed, it can be a public access document itself. So in essence, what does your medical record convey? How will it be interpreted? Will it show the type of care and the rationale for care that you intended? Perhaps that's the young woman that many of you will see in this image? Or will it be another story that does not show clearly what your logic and your path of care involved? What kind of thought process was it? Would it be that elder woman that you would see or they would see? So it's very important not only to have documentation, but to have that documentation match what your thought process was and the care that you rendered. We look at claims and what is a viable medical malpractice claim. There are usually four elements that you can look at to see on whether there's viability in that allegation. First, there was clearly a duty to treat a patient that has been breached. There is a deviation from the standard of care or the care a prudent ophthalmologist would provide. There is a deviation from that, and that is determined by the use of expert witnesses on both sides, both the plaintiff for the patient, as well as for the defense for the physician and the healthcare entity. There's a direct causal relationship between that deviation and any alleged injury or damages. And finally, the damages themselves, both economic and non-economic. And I point out that if ultimately there is a payment of liability to a patient for damages, that's known as an indemnity payment. And then there's another bucket of expenses, legal expenses, that are for the management of the claim itself. So what to document? Certainly the pertinent clinical history and the other elements that you see on this slide, including other courses of treatment if the current treatment plan does not work. It's very important that all of these elements be in the documentation in some place and manner so that others can view and see your rational plan for the care that was provided. Let's look a little bit further into the type of documentation at different phases of care. And we're, of course, going into surgical documentation and in the diagnostic and preoperative process where you're determining what the patient needs. Your documentation should show your thought process to aid other providers as well as aid in the defense of a claim. The informed consent process, specifically within that diagnostic and preoperative phase, is very important. What is informed consent? It's an oral agreement reached after the surgeon advises the patient of the diagnosis and proposed treatment, the risks, benefits, alternatives, and potential complications, and the consequences of not refusing that treatment. The informed consent should be documented through a note in the medical chart. It can be the physician's notes or other staff members that are aiding in that informative process. It can be the procedure-specific consent form itself. You are going to have cataract surgery. Here's what cataract surgery is entailing. Here are the risks, benefits, etc. And both of those parts of documentation memorializes and confirms that the conversation with the patient has occurred. Let's look at a specific claim example to illustrate this. A lid lesion excision, and in this case, the documentation did not clearly state why this procedure was done. The patient sued after developing diplopia and excessive scarring when a lid lesion was removed. No documentation of any patient complaints about the problem leading to the excision could be found in the chart or overall in documentation. The patient experienced, unfortunately, a rare idiosyncratic immune response after the process. And while the defense expert felt that scarring which occurred could not have been anticipated, the defense expert further stated that there was criticism of the care due to the lack of documentation on why the surgeon decided to excise the lesion. In this case, the case was settled for $95,000 due to that deficiency in documentation. Let's look further in the preoperative preoperative process and the lack of consent involving a cosmetic chemical peel case. This is a 62-year-old female that had a cosmetic chemical peel done on her. The allegation is that that peel was done negligently, leaving her with facial scar from the cheek to the upper lid due to an infection that occurred after the procedure. The allegations and the issues were that there was lack of documented informed consent or discussion of the procedure with the patient, no documentation of the patient's chief complaint, in fact, no discussion of possible infection, which could occur as a complication of the procedure. While there is no deviation from the standard of care, according to an OMIC reviewer, the case did unfortunately proceed to trial. And after a 2-day trial, there was a defense verdict. The point here is that the allegation of lack of defense here, lack of documentation, led to quite a bit of time and expense, upward of $125,000, to defend the physician involved. Now, this figure of $125,000 is a lot in itself, but what is not accounted for is the time away for the physician from his practice to respond to this allegation and to defend himself on the claim. So with better documentation, this could have been avoided. Okay, let's look at another case. And this time we're going into the intraoperative care phase. And this is a retina case and the allegation of negligent care and the finding in that there was inadequate documentation. So let me show you what that inadequate documentation consisted of. First, we have a 48-year-old female with a complaint of foggy vision and a sudden decrease in visual acuity, a past medical history of DVT, hypertension, and diabetes. Patient was on a thinner. The diagnosis was PDR and macular edema in the left eye more than the right. The patient had a history of PRP and Avastin injections over the previous 2 years, and was making good headway, good vision in both eyes. But suddenly there was onset vitreous hemorrhage in the right eye. At that point, a planned vitrectomy with endolaser was planned and actually done 2 weeks after this diagnosis. And yet the patient was no light perception in that right eye after the procedure. The issues in this case is it certainly was a complex case, but there was poor documentation to guide others on what the thought process and the care that was rendered to this patient. It was unclear also who was performing a certain aspect of care during this care plan, and I'll elaborate on that in a minute. So the outcome, according to the claim review, the reviewers felt a poor outcome was likely, but bad documentation made the case difficult to defend. Other surgical options were available, but were not discussed or at least documented in the medical record. Overall, that gave an impression of questionable care by the providers and staff and led to a settlement of the case of $600,000. I do note that the state where this claim occurred does not have a cap on damages, which led to some pressure to settle the case. Going further on this retina case with a vitreous hemorrhage, documentation issues specifically. There was lack of documentation on including what evaluation was done on the patient, specifically treatment with drops, as well as post-treatment to monitor the intraocular pressure. There was a lack of informed consent, specifically treatment options to the vitrectomy, and lack of documented discussion about anticoagulants prior to treatment that could lead to hemorrhaging and bleeding. Most notes in the chart actually showed a normal value on all visits, even though the right eye became tisical at some point. The IOP was not checked and documented routinely. And further, no note regarding the use of SF6 gas, both the amount and concentration that likely led to the increase in IOP was found in the documentation. So as you can see, all of those things did not, that documentation deficits did not portray a very clear picture of the care that was provided. On top of that, it was unclear who performed the paracentesis on the patient at some point in the care, and it was even ventured that an ophthalmic tech did that procedure, which was clearly out of scope of this individual and pointed to lack of supervision by the surgeon and also some liability pointing towards the practice entity themselves, which employed that technician. Again, the settlement of this case was $600,000. Let's look at a post-operative phase of care and the clinical care that was provided with a glaucoma case. In this instance, we have a 70-year-old female complaining of tearing and blurred vision. A diagnosis of dry eyes was made. The ocular history of this patient is that she was being treated by both an MD and an optometrist with topical tears, cyclosporin, punctal plugs, antibiotics, and intense pulsed light therapy, IPL therapy. The patient developed cataracts over a 2-year period, and this was likely due to the use of steroids. Cataract surgery was performed and a premium IOL was placed, but subsequently there were complications and a piggyback lens in the left eye was needed. The patient's chief complaint at that point was blurry vision, diminished field of vision, depth perception issues, glare, and sensitivity and smudging in the eye. Clinical course of treatment was undiagnosed low to normal tension glaucoma. Visual field and glaucoma and neural consultations were not performed until cupping increased to 0.9 in that left eye, and there was an afferent pupillary defect found. What also complicated the defense of the claim was that the practice was moving to a new EHR system, and that created some gaps in the type of documentation that was noted in the patient's chart regarding their treatment. Claim was filed ultimately for $750,000. That was the demand. Defense counsel estimated a settlement range of $200,000 to $250,000 could be obtained. Clear liability was noted. The case, fortunately, was settled for a lower amount that you see there, $162,500. But what's interesting is that 60% of the liability was attributed to the practice itself, the practice entity, secondary to system failures around the MD. And that would include the actions or inactions of the optometrist, because the optometrist was hired through the practice entity. 40% of the liability in the settlement amount was assigned to the physician themselves. So getting to risk management, and then I'll further comment on that liability assignment, the percentage. Documentation deficiencies, poor documentation of medications once they were changed, getting into the EHR. Poor documentation of problems, especially steroid response for this patient. We could not find a clear thought process on prescription of these medications, why they were needed, what was the plan for the medications and tapering. Tests listed in the EHR could not be found in the records. And further, the co-management that was occurring with this patient, co-management meaning the providers, both the MD and the OD, there was a lack of communication documented, lack of a plan that the two providers had in terms of how to manage that care, lack of oversight by the MD over the optometrist's actions. And as the higher level trained individual, even though the optometrist is independently licensed in a co-management situation, the MD or surgeon would have some added responsibility to ensure that there was a clear plan on when the optometrist would be referring the patient back for care should there be a complication. And lack of identifying glaucoma in the patient early on was also found in peer review. The failure to diagnose then overall, the failure of the optometrist to do optic nerve tests and follow the patient closely was determined. Failure to interpret studies was also found. And lastly, failure to conduct proper tests to monitor the patient. And then in addition to that, they found from a system standpoint, the office, the practice entity itself, did not follow their own medication refill protocol for the steroids. And refills were provided without checking with the physician. And that led to some issues that you see in the damages that were alleged. So another area that we can look at and the importance of documentation is evident is in dealing with errors, medical errors that do occur. We all recognize that those occur, but how they are handled and how they are documented is important. Let's look at a PRK case to illustrate that and the failure to document disclosure of a medical error. In this case, we have a 46-year-old female that presents for refractive surgery. PRK was determined as the type of treatment needed. Patient had a history of LASIK 2 years prior. Patient's complaint, blurry vision, diminished field vision, depth perception issues, glare, sensitivity, and smudging. The clinical course, as I mentioned, PRK, and it was performed with no complications. However, post-operatively, day one, the vision is 2250 in the right, 2150 in the left. It's not as expected. 14 days post-op, in fact, the physician, the surgeon, checked laser records to see what could be causing this vision outcome, and noted a transposition error of 1.25 was entered on the refraction laser versus minus 1.25. That was determined to be the likely cause of the visual outcome. At 15 days, a day later, the patient is on the phone with the surgeon, and they have a 8-minute phone call, but there's no documentation of the discussion that the patient was told of the transposition error. The doctor indicates he asked the patient to come in to discuss their eyes, but he did not disclose the error over the phone, or he did not document that he did. And that is where a major issue in documentation took place. Failure to diagnose an error post-op. The medical record has no mention of that error, as I noted. Patient found out about the error, in fact, 6 weeks later from a technician in the practice. Punitive damages at that point, due to an allegation of concealment, started to come into the claim itself. And I do want to note that punitive damages are not covered under a typical medical malpractice insurance policy. So if punitive damages were to be found, that would be something that would go directly to the liable party, the physician in this case. So with that type of issue with documentation and the concealment allegation that was in place, it was decided that settlement in mediation would be best, and the case was settled for $200,000, mainly off of that lack of disclosure. And that was unfortunate because if that documentation had been in place, there would have been a different outcome in this situation. So let's look now at noncompliance and refusal of care. And I cite here a ROP case as an example. We have parents refuse to return to a facility according to their primary care doctor. It's also documented in an EHR. These are twin babies at 28 and 5/7 gestation period. ROP risk is evident, and yet the parents do not bring the babies in, the twins, for 2 appointments in a row, and due to the sensitivity of time sensitivity of ROP care, should it be uh, found that condition does show is present, the parents there was a concern on what to do, how to document appropriately, and what made the issue even more sensitive is that other treatment options were limited in the area, other providers specifically. So if there was a relationship issue with the family and the care provider, those options were very slight. The patient and the babies would need to be traveling a greater distance to obtain alternative care. And so the risk management advice in this situation is to bring in Child Protective Services to document that a third party is being called in to help express the urgency of the need for screening and for care should it be needed. So documenting noncompliance is the issue here, and how to do it. With an ROP case, it became evident that CPS or Child Protective Services would be needed. But in other types of noncompliance situations, there's still that issue of how do I document this noncompliance? And we have resources on our website for both ROP care specifically and for non-compliance in general. And both have templates for letters that can be sent to patients or to parents of minors to impress upon them the need for continued care, and most importantly, the consequence of not obtaining that care. And what you want to document in these situations is that care is needed, that you've had a discussion about the non-compliance, the risks, the consequences, and you can send either a refused care letter saying, Mr. and Mrs. Jones, you have been advised about the risk of care for yourself or for your child, and you are consciously refusing that care. You want to document that that is the decision of the patient or the guardians, and then have them sign that form. And if they refuse to fill out a form like that, to send a similar letter outlining what the discussion was with these individuals and um, trying to impress upon them to reconsider. So we have a resource, Guide to Noncompliance and a refusal of care consent form that can be modified for your patients for this purpose. Now let's move into technology and how documentation can be impacted in a pro or con way. Electronic healthcare pitfalls still remain, even though EHRs have been in use for at least a decade. And really, they fall into two different buckets, user errors versus system errors. And what we recommend is that you keep a log of the type of issues that you have with your EHR system and try to determine whether it's user or system related. If it is a user issue, have someone designated on your staff as a super user that can help retrain, provide in-service, and eliminate those EHR issues that are user related. Be careful when delegating EHR privileges. Not everyone should have the same privilege level to view and edit records, because sometimes the errors in EHR are inadvertent omissions or deletions of critical care information. Document who has what privileges so staff know who to go to if certain actions are contemplated or they think must be completed. System issues, on the other hand, should be reported to the EHR vendor, asking, is there a workaround? Is there something that can be done to modify the system? And you want to document those events as well. And does your vendor periodically upgrade your system? If so, make sure that those upgrades are conducted and that there are tests that are done. Again, it can be a super user that can run some tests on the EHR upgrade to see if it is functioning properly. So those are the two main buckets that you should think about with EHRs, and more importantly, how you should address them. Both involve documentation, both involve taking action to make sure that that issue is resolved or a workaround is develop that is acceptable to your practice. So the pitfalls remain copy and paste functions, copy forward functions, and cloning. Those can convey an appearance that you may not be rendering the type of in-depth care that you need. Sometimes auditors can see repeated entries with the same wording, and they can question and ask for a series of charts with the allegation that I wonder if you really are rendering the care that you're stating in your EHR. Wrong choices in pick and drop down lists are also a problem due to a fast pace of a clinic, heavy patient population. So the need to be accurate and to have some quality assurance in there. Failing to update medication lists, the use of normal defaults rather than um, entering what is the findings, insertion of macros that are not edited for individual patients that can either cause a note bloat where there's just too much extraneous information or it doesn't have specific information about that patient. And information in one part of the record contradicts another. Is your EHR system, are the entries being made logical as you move through the record, and is important information in the proper place? Sometimes amendments to a record can be in a separate file area and easily overlooked. And again, just simple but very, very important recommendations. Do not share passwords. When you share passwords, it compromises the defensibility of a claim because the credibility of who actually made that entry or sign off comes into question. So this recommendation and this slide specifically was requested because a very large practice, very sophisticated, very excellent care reputation, still faced this problem where passwords were being shared, passwords were being put on post-its in public area or in areas where others could use and access a record or a functionality. Do not do that in order to protect the integrity and the privacy and the authority of the record. Text messaging and email. Certainly text messaging, according to CMS, texting is okay if it's through a secure platform. Always be aware that text messaging should remain professionally written and complete. It is being requested more and more with medical record requests. If you're sending text messages for patient care orders, they recommend that you not do it through a normal general text messaging system, but through a patient care order system that is secure. Computerized provider order entry is the method for submitting those orders. Email, according to the Department of Health and Human Services, it's okay to email with reasonable safeguards. Check email address for accuracy, limit accuracy and updates. Sometimes parties move. It might be that they are giving you business addresses and they've moved to a different business. So always verify that email address. Limit the amount of PHI or protected health information disclosed when using unencrypted email. I would recommend that encrypted email be used whenever patient information is being transmitted. And as far as authority to use email as a channel of communication, if the patient has initiated that, you can assume it's okay. But I would recommend that privacy preferences for a patient, which would include the means by which they can be contacted by telephone or email or text message, be explicitly provided to you by the patient so that there's no doubt that you can use those channels for communication. Don't practice medicine over email. Keep your messages very concise and very objective. And make sure those emails get into the medical record, just as the text messages. Those need to go into the medical record as well. And the patient overall has the right to opt out of email or text messaging. They have the right to dictate how to be communicated with. So something to remember about digital and electronic records is that they are discoverable. Assume someone can read over your shoulder. just in terms of privacy. Lock your phone and have the ability to remotely delete information on your electronic device should it become stolen or lost. Safeguards for using digital and electronic devices is the point here. So documenting phone calls. I know that you all have long clinic days, and usually telephone calls are made at the end of a day in many cases. Make sure, however, that you and your staff um, are aware of the importance that you document those calls. The discussion with the consultant be documented. After-hour care with patients, especially if you are on call to your practice group or with an ER, make sure that you document all of those transactions and all of those patient encounters. And patient sign-offs when you're going on and off call, make sure that the next person assuming care knows that they are responsible and that you've handed off that case to them. So telephone calls should have all the information that you see there, date, time, etc., recommendations, follow-up, communication with other providers, an OMIC resource and a checklist that is offered there as an example on how to set up your documentation expectations can be found in the OMIC resource entitled Telephone Screening of Ophthalmic Patients. So remember to document and remember to document properly. So learn more about everything that I've covered today, co-management, after-hour calls, office telephone screening, no-shows, emergency room care, transfer of care, referrals, termination of care, and ROP on our website. And it's listed under the risk management tab of omic.com. So I hope that this course has been useful for you. And I thank you. And for many of you that are part of a state or subspecialty organization, you've earned either a 5 to 10% premium discount, and your organization will guide you further on how to send that verification of participation in. If you have questions about anything that was covered or would like elaboration on it, please email us at the email address noted, riskmanagement@omic.com, or call our office at the 800 number noted there, entering 4 for the risk management department. And with that, I'd like to thank you again for your participation in this course. And this concludes my presentation.